Welcome to Discovering Africa Through Technology, the podcast series that showcases the brilliance of Africa's great minds, innovators, and experts as they tackle complex challenges with homegrown solutions driven by knowledge, technology, and innovation. Our podcast is inspired by the African Union Agenda 2063 Aspiration 7, which seeks to rebrand Africa and change negative narratives and perspectives through science, technology, and innovation. We believe that Africa has the power to solve its own development challenges and become a strong, united, resilient, peaceful, and influential global player and partner. Join us as we explore the transformative potential of technology in Africa with your host, Razia Kulatein Mwanga, and learn from the experts driving change on the African continent.
Today we are talking to Professor Larry Akoko, who is a specialist surgical oncologist and researcher, and we shall be talking to Professor about Breast Cancer Awareness Month.
I'm a medical doctor, trained general surgeon, subspecialized in treating cancer by surgery. I deal with breast cancer and soft tissue cancers and the whole of GI from esophagus to the anus and the solid organs within the body. Trained locally, but also trained in one of the largest cancer centers in the world, that is in Tata Memorial Hospital in Mumbai, India. Proud to be one of the pioneers of surgical oncology.
How did you get into oncologist?
In the past, there were very few subspecializations. In my early years practicing as a general surgeon, working with both kids and adults, I realized that we were having not very good outcomes with our cancer patients. And so I did not understand this profession, subspecialization called surgical oncology. Initially, I thought I was already a surgical oncologist because most of our elective surgeries, planned surgeries, would be cancer anyway, until I met well-trained surgical oncologists from America and Europe. And I realized that the skills they had were just superfluous. They're not what I've ever seen. Many times you'd want to operate on a cancer and you'll be limited. You'll say, this cancer cannot come out. And when you operate with them, you see that the amount of things that they'll take away with that cancer because of their experience. I also realized that one of the leading causes of our admissions was cancer. Thought it was time that somebody, a Tanzanian, specialized in surgical oncology to help train other future surgeons in surgical oncology. And then came a Merck Foundation. It's a German pharmaceutical giant that supports training in Africa. They're in fertility, hypertension, diabetes for a longer time, but they just started supporting oncology. I was the second batch from the African team that was being sent India. So from Tanzania, I think I was the third candidate being supported to do surgical oncology. The first one was a medical oncology, and another one was taken to learn how to do research in head and neck cancers. So that's how my interest came about.
Is there a specialization in surgical oncology?
So that's a nice question, depending on context. If you go to India, they still have what we call a surgical oncologist. And if you look at it, it's still very general because then you are training in everything. You are training to do neuro-oncology, chest oncology, head and neck, breast, GI, urology, orthopedic, pediatrics, obs and gyn. That's too much in 4 years. We already had orientation in Tanzania where we already had people specializing in all those fields. So when I went to India, I felt like I don't need the surgical oncology thing. So I customized. I was the first one among these African scholars who decided that I was going to narrow to an area that resembles what I was already practicing as a general surgeon, but now as a surgical oncologist. So if you look at general surgeon, most of our cases would be a breast, would be a soft tissue, and would be GI, digestive system.
Let's talk about Tanzania. How many surgical oncologists are there?
It's always a tough question. Best way to ask that question is how many trained. Surgical oncology trained in my capacity. As surgical oncology, I'm the only one. But then there is an American model here where you do surgical gastroenterology. So surgical gastroenterology, while meant to largely do transplant, but they're also trained to do the alimentary tract cancer during the surgical gastroenterology training. So those are about 10. But we also have a gyne oncologist training to do oncology in gyne. So we have two of such kinds. We have about, I think, 3 head and neck surgeons, a urologist, though not trained in uro-oncology, but most of the electives would be oncology, as I said. So it's normally difficult in a population of 60 million people to say like we are only 10 because we can't handle the burden of surgical oncology. So when it comes to trend, then we are few. So in my field, then I'm the only one.
How is your typical day? Because if you are like the only one, how many surgeries on average do you do per day?
That's why I was afraid saying I'm the only one. Because then I can't survive. So there will always be procedures that we call low-hanging fruits. They're easy to teach somebody else to take over. So that's what we call the task sharing. So like it's very easy to teach somebody else to take over breast cancer. And I've trained many. So breast cancer no longer shoulders in my no longer hangs on my shoulders. It's no longer a burden to me. I rarely go in on special cases. And GI, as I said, we are sharing with about 7 GI surgeons at Muhimbili National Hospital where I work. Yeah. But again, many patients, as I hope will be coming there, come very late. So there's very little to be done when it comes to surgery. But otherwise, on a single GI surgery, like if cancer is in the pancreas, it's all day surgery. That keeps you busy. But fortunately or unfortunately, many patients come in a condition where they are not operable. So that again alleviates significant work when you are alone, but not also not creating a good environment for local training, because then the volume is low. But typically it's busy. Dealing with cancer patients is not easy. Even when you are not operating, telling a patient and the relatives that there's nothing that can be done is itself a very big burden. Acting like God, like this is the end. Nothing is possible. That's difficult itself than operating.
Talked about almost like 10 people doing this. How many women are there?
Women doctors, among the ones that I counted?
Yes.
One, gyne oncologist.
So now let's talk about cancer. This monster
Yes.
in the room. What is cancer for somebody who doesn't know cancer? Is it a bacteria? Is it a virus? Is it inherited? Is it contagious, airborne, waterborne? What is cancer?
For one to understand cancer, one needs to understand how the body is made. So this body is made of cells, and these cells die almost every day, every minute, and new cells are formed for cells that regenerate. Typically, if your cell drops off, the body should make a similar cell to the one that just died. So we call that apoptosis. It's a natural cell death. So they are like traffic police on the road, meant to pull aside cars which are driving wrongly, not obeying the traffic rules. So the body also has cells that check when these new cells are made. Are they made exactly to the specification that they were supposed to be made? So when for one reason or the other, that check mechanism switches off, then cells that are not made exactly like what they were supposed to made proliferate, they grow in number. And this is what we call cancer. So it is not an infection, it is not contagious, but it is an abnormal growth and proliferation of our body cells.
And neither is it bacterial or virus.
So bacteria, virus, environment will become like things that either triggers our body to those cells to misbehave, or do what we call promotion. So like maybe my body was made from the beginning that I will develop cancer, but it's just waiting for this bacteria to come and switch off that control system, or to come and cause those cells to grow abnormally. So yes, bacteria doesn't cause cancer directly, but indirectly some bacteria, some viruses, something in the environment, something that we eat, something that we drink, smoke, some pollution in the environment will cause cancer.
I love the analogy of the way you've tried to explain this in terms of traffic police waiting to stop cars. So let's go back to cancer. Like, how many types of breast cancers are there?
When you come to types, then that's more scientific. That now you want to classify them based on cell type, because the breast is not made of one cell. So the breast is made of lobules, which are like where milk is stored, and the breast is made of ducts, which is like when milk is stored, then milk has to pass to come to the nipple, so it passes through ducts. So breast has lobules and breast has ducts. So if cancer starts from the ducts, then it is called ductocarcinoma. If breast cancer starts from the lobule, then it is called lobular carcinoma. So ductocarcinomas are more than lobular carcinomas. These ducts and lobules are also connected by connective tissues, which are many. So if the cancer comes from the connective tissue, then it's a sarcoma. If the cancer comes from the areola, the nipple areola complex, the black thing around, because normally you have a brown skin and then somewhere it's dark with the nipple. If breast cancer comes from that complex, then it's also a Paget's disease, which can be a cancer or benign, depending on what it is. So breast cancer is classified based on what tissue is involved. And so from our perspective, we use WHO classification. So we'll have ductal carcinoma, lobular carcinoma, medullary carcinoma, anaplastic carcinoma, we'll have phylloides tumor, we'll have sarcoma. You can have lymphoma also of the breast.
There's also this other common term when doctors tell you that your cancer is invasive or non-invasive. What do they mean?
The moment you say cancer, it is cancer because it is invasive.
Okay.
So you can have a swelling in the breast that is not invasive, then it is not a cancer. So like if you're a young girl and you are feeling something in your breast and you're trying to hold it and it slips away, we say you have a fibroadenoma. So it's a swelling in the breast, but it is not cancer. Why is it not cancer? Because it is not invasive. What is invasive? Invasive is the ability to invade tissues and spread. So when you have a swelling that has no ability to spread, then we say this swelling, this swelling is not cancer. We say it is cancer because it is invasive. Breast cancer grows in stages. So you'll have what we call a cancer in situ. So ductal carcinoma in situ, for instance. It's a cancer, but it has not yet invaded the supporting layer of the cells. So there'll be cells here that have cancer. And this cancer has not invaded the basement because there will be a layer where these cells are laid. So then we'll be saying you have a carcinoma in situ for ductal carcinoma. It is still cancer, but it is not yet invasive. So if you can remove the in situ, then that treatment might be all that a person needs because your cancer was not yet invasive. Yeah, so most cancers have got that in situ component, and then they progress to become invasive.
Talking about Tanzania and probably Africa, but mainly Tanzania, what are the most common cancers?
We normally use Global Can data, the Global Cancer Observatory Group. It's an agency of the International Atomic Energy Agency based in France. It collects data about cancer globally. It comes every 2 years. The one that's already out is data for 2022. Cancer of the cervix is the leading cancer in Tanzania, regardless of sex. Of course, it's a cancer of female only. Then it is followed by breast cancer, which is also largely female, but even male can get breast cancer. But overwhelmingly, I think cervical cancer is very higher, almost 200 or 300 times more than breast cancer. But then we also have colon cancer. We have esophageal cancer, which is also very common, though with geographical distribution favoring Kilimanjaro, Iringa, and Kagera, where it is more. We also have stomach cancer. We have liver cancer. We have prostate cancer among men. And we also have various skin cancers. We have leukemia, which is cancer of the blood. We have lymphoma also. I think that makes the list of our top 10 cancers.
Why do we have more cervix cancer and breast cancer compared to other cancers?
Way back when I was a student, breast cancer and cervical cancer were equally reported because patients have to get sick and come to hospital. That's how you get cancers. So of recently, I think you know that we have been having this awareness about cervical cancer, and there are a lot of funding that supports screening to the village level. And so this one led to a hype. So when you see this, it's normally difficult to say whether there's more risk factor for cervical cancer than other cancers. You first have to look at it like there's more awareness, there's more screening. So they are detecting more women with cervical cancer. If we were to screen for breast cancer as well, the same way we have done with cervical cancer, it's my guess that breast cancer would exceed cervical cancer because globally breast cancer is leading. If you combine all cancers, regardless of sex, breast cancer always interchanges with lung cancer in terms of prevalence. But again, globally, in the global West, there have been vaccination campaigns and screening campaigns and early detection of those early lesions. Because I said cancer doesn't grow overnight. You start by having abnormal cells. So when you detect this abnormal change of cells, in many Western countries, they would offer them treatment. So treatment is available. So that's why the West is reporting very little of cervical cancer, and we are reporting a lot of cervical cancer. Our screening just began, I think, 5 years ago, and vaccination campaign drive. So I believe the young girls that we have today, most of them will not develop cervical cancer when they become adults because they have been vaccinated, and that will lead to a decline in cervical cancer. But it will have to wait until this population that is being vaccinated now, which is primary school children, reach that numbers, which will be about 20, 30 years to come from now.
You talked about some regions having specific cancers. Why do you think that is common? They had more women who had more cervical and breast cancer coming from the Lake region. So why are some cancers more concentrated in some parts of Tanzania than others?
That's a myth that we don't know. You remember there was a time when people think like Lake region had the highest cancer incidence than the rest of the country, whether it was to do with the fishings. There is a way environment poses risk, and we have not understood yet what's this environment. So you look at Lake Zone, you look at it like most populated than some other regions that we want to compare it with. So with that population, with the higher birth rates, so you are going to expect more cancers. More of any disease will be higher in the Lake Zone. But then if we have complete picture, then you want to start you want to segregate based on what are the activities in the environment, like there's fishing. But around this fishing, there is mining. And around mining, there is cyanide, there is mercury. If you go to Kilimanjaro, Kagera, and Iringa, These are plantations, so they have got pesticides. They all grow banana. Is the problem in the banana? Is it in the crops? Is it in the inhalation? So all this will dictate what type of cancers people have, like urinary bladder cancer, for instance, which is more in places where they grow rice because of schistosomiasis. So you will see it in Tanga, you see it in Morogoro, you see it in Kiela. And now rice farms are spreading all over. People are growing rice where we were not used to seeing rice. Like there was no rice from Sumbawanga. Now there's rice from Sumbawanga. So people from Sumbawanga will start coming also with schistosomiasis. And it's because of ignorance again. We know how to prevent ourselves from getting schistosomiasis, which will cause chronic irritation of our urinary bladder. And this chronic irritation with eggs deposited will later lead to urinary bladder cancer. So things like that. But I must admit that we have geographical pattern, even across countries. There are cancers that you'll see in Tanzania. You'll not see them in Uganda. They don't know about it. But we don't know yet.
Let's talk about early detection, because you talked about most of these people come late. In terms of Tanzania, how is it done? Because like, is there a record from when you think you have a problem until when it's diagnosed? What's the window like?
I think that's one of our greatest challenges. I did a paper looking at the journey of the patient with breast cancer. And we were thinking that whether we were having an aggressive disease or we were having a delayed presentation. And we realized that most of these patients had actually gone to a facility when they first had a lump, maybe at a centimeter or so. But look at this country and look at where that facility is. So I normally give example from Kahama. That's where I worked as a medical officer. And you are in Kahama sitting in the district hospital, and there's a patient 40 kilometers in a health center. And for them to reach that health center, they traveled maybe another 40 kilometers. And they are being told you have a lump in your breast and you need to go to the hospital. And the hospital is 40 kilometers or sometimes 100 kilometers. So they will not go to hospital that day because it took them time even to plan to come to the health center. So they'll go back home to think. And then it grows. And then they say, okay, now we need to go to the district hospital. They come to the district hospital, and the district hospital tell them, I think you are having a cancer. You need to go to Muimbili. During those days, Muimbili was the only place where you treat cancer. They will not go straight because their travel arrangements did not include traveling away from Kahama. So they'll go back home and they'll have to make another arrangement. And those will be months. So maybe it's the 7th month. Then they come to Muimbili and then they are late. And then you start saying, why are you late? You are very negative, not supportive. The disease itself is advanced. They will not get well with the treatment. They'll go back to the village. So this patient will die. So word of mouth. Yes, they took something from the breast, and she got very sick. So they will not want to come again. So I've always thought of the country is very big. We had invested on, due to scarcity of resources, you need to have one best hospital. But I think the hospital that treats cancer are very far from where people are, and patients are not supported to seek referral. They're just being referred, but nobody actually understands the hassles that the patients need to take from the village to the hospital and the family that they're leaving behind. Because if it's a mother with breast cancer, it means it's coming with the husband. What if they have kids? Who is remaining with the kids? All this will go into their calculation. Should we wait until the farming season is over, until we harvest, until we leave food home, so that the kids can continue eating when we are away? So working in the village has taught me to always think of the difficulties these patients take to come. It's always difficult.
Are all the doctors trained to screen for cancer, like general doctors, so that when people go to hospitals and they are complaining, they are thinking it is cancer, Do they have do they do that so that this could probably help save more lives?
Yeah, so doctors, all doctors are trained on suspecting a cancer. You can just suspect it. When you suspect it, you need to order some investigations. Those investigations normally are available in also very few centers. Like I can tell you that most of our regional hospitals cannot diagnose cancer. I'm not saying they cannot suspect cancer. They can suspect you have a cancer, but they cannot diagnose a cancer because you don't diagnose cancer by seeing it. There are many things that would mimic cancer. I got a lady who had struggled with the TB of the breast for a year. And she was almost being started on chemotherapy because even with the modern diagnostic capacity, they could not diagnose what it was. But given my experience when I saw it, I said, this is TB. Just treat for TB. After she had suffered for a year, she had lost over 60 kilograms of weight. So when she started anti-TB, it got well and gained her weight, and all the lesions she had in the breast disappeared. So it's very difficult to say that a doctor cannot diagnose a cancer. They don't need to diagnose it. They need to think of it. And they do think of it. The problem is when they think of it, they're telling you, I don't have this service. You need to get this service in another hospital. And that hospital is not very convenient with the patients. So now, just to step forward and answer what are we doing as a country, we are now thinking of referring specimens. So this doctor, when you suspect a cancer, if you are in Muimbili, what would you have done? You would have taken a specimen. So we want these doctors to take specimens. The patients will pay for the specimens where they are, and this specimen will be referred to where it can be tested. So that results come back and say, this is cancer, and the patient will be called and they'll be told where they need to go for treatment, rather than one referral center to the next, to the next, to the next. So they go when their treatment is fully planned and booked. That's the plan.
As you've said, the problem is the late presentation and also resource limitations and equipment. That is what makes it hard. So going forward, let's talk about the surgeries. So if a person comes and they've already been diagnosed with whatever cancer it is and they have to go through surgery, take us through how that is done. And are patients given, do they have enough knowledge on what type of treatment they should get? And do they get an opportunity to choose what they want? And for example, you go in there and you find that we have agreed that you should just go and just remove this part, and you go inside and you find that this is beyond what I had thought. What happens also to the patient's rights?
So normally, how I will talk about how it should work, then how it works here. So managing cancer is a teamwork. Like I'm a surgeon, I need a medical oncologist who will be thinking of which medicine to administer. I need a radiation oncologist who will be thinking of if radiation is needed. I need a pathologist who will be confirming my diagnosis. I need a radiologist who will be helping me taking the images. If they're young, you need a genetist who will be talking about genetic risk and counseling for testing. You need survivors, because I've never had cancer myself. So I will not be the best person to talk with patients on the journey of their cancer. So normally survivors come in to talk to this patient so that they also get it from an understanding of somebody who has gone through what they're about to go through. And then they'll always be a fertility expert, they should be, because when patients are young and they have desire for family, they should have somebody talk to them about what options are there for them for future families. We also have palliative care experts, because you start palliative care. I hope you understand palliative care.
Yes, that's
Palliative
after
care is when you
cancer
start
care.
making arrangements of your future. Because with cancer, you know you have a disease that might kill you. So what are your plans? So palliative care is not end of life. It's the whole thing, your plans. So you meet the palliative care person, you meet a pain specialist. So it's a big team. So in that big team, by the time patients meets all these people, patient will be well educated about their cancer. Come to our situation now. That team is not there because bringing in that team is a wage bill. Nobody can bring that team. So the doctor should give all this information. It is never possible because you'll spend 1 hour with one patient. With the patient load that you have, it is never feasible to take patients through everything that they need to know. But at least the basics that they need to know to decide on a treatment that they're going to get will be offered by the doctor. So they're given counseling. So when you counsel patient for breast cancer, it's straightforward because the breast is there, everybody's seeing it. But when you are counseling patient for a cancer that's inside the body, it's never easy to know what you are going to do. You can only say what you are planning to do. It might not be what you are going to do. You might open and back off. It's not possible to do. You might open, you said you are only going to move this small part, and you find it's involving another part and another part, and you need to remove all of them. So the most important thing is that counseling and patient education is continuous. So after surgery, when patient is fully well, maybe 2-3 days, you will be talking to them again, patient and the family, not the patient alone, because patient did not come to hospital alone. Patient came with people whom they consider are their most important treatment support group, the family. So the family must be present during all counseling sessions, provided the patient have agreed to it.
In Tanzania, what are the most common forms of treatment after surgery, and why? I know different cancers require different treatment. Chemotherapy is expensive, radiation is also expensive. So like, how do you get to determine whether this patient should get radiation, should get chemotherapy?
Surgery and radiation are meant to control local disease. When I say local, it's like breast cancer, this breast cancer here. So controlling it locally here is surgery and radiation. Anything drug, which can be chemotherapy, can be immunotherapy, can be hormonal therapy, anything medicine taken is meant to control cancer that has gone away, not the local cancer. So this, we call them neo-adjuvant if we are starting with them, or adjuvant if they are coming after surgery. So neo, before surgery, adjuvant is addition. So surgery is in the middle of care. That's why you need teamwork. Before the surgeon makes decision, the chemotherapist and the radiation oncologist must sit together with the surgeon and decide what's best for this patient. So this is normally based on research and what has been shown to work. So not all cancers will require chemotherapy, and neither will all cancers require radiotherapy. So tumor biology, outcomes of surgery will determine most of this. Some cancers just can't be operated and will just require any of the two, radiotherapy or combination of radiotherapy and chemotherapy.
And let's talk about the cost of these services. How cheap are they? And do they
They're not.
determine like why should I go for this or that? Like how much does it cost to do that? And like normal, in a minimum, those like chemo rounds, like how much does a chemo round cost? And if radiation standard, what's the standard of treatment for a patient, and how much does it cost? And who foots the bill?
So while I may not be an expert in price,
Mm-hmm.
but one thing I do know, treating cancer is very expensive, very, because it's longer. Let's take an instance of breast cancer. So if you start with the chemotherapy, those will be 4 cycles of chemotherapy, and that will be 4 months of just chemotherapy. If the woman chooses to do breast conserving surgery, that you just want to remove the swelling and remain with the breast, then after 3 to 4 weeks of recovery from surgery, this patient will need to complete chemotherapy, which might be 2 cycles, that's additional 2 months, and will need radiation therapy, that will be like a month. So depending on how much chemo is given in the neo, that treatment can last up to 9 months of treatment. So chemotherapies are never given as a single agent. They're given in combinations. So the minimum combinations that exist are combinations of 3 drugs. And so normally we adopt guidelines based on international guidelines, what is working. So we are very much up to date, and that's expensive because we are not doing our own research to see whether cheaper ones are equally efficacious. So since we don't fund research, so we follow protocols of people who do research. Yeah. So they're expensive. A single round of chemotherapy, I think, would cost somewhere around 800,000 in private, very cheap private hospitals. And it will cost about 600,000 in a government facility for a single round combination chemotherapy. So normally what happens when patients cannot afford is patients will end up getting what is available. So if they're supposed to get 3 medicines, maybe there's only 1 available, and they'll get that 1 available, which will not work very well. So you cannot compare your outcomes in research with others who are giving standard treatment. And radiotherapy is also equally expensive and has one of the longest waiting hours in chemotherapy, just like surgery, because it's a procedure. So they have a very long waiting time to when a patient will be started on radiotherapy.
Wow. So most of these people
So
die
it's expensive.
because, like, even the minimum wage is less than this amount.
Leave
600.
alone the wage. Leave
Mhm.
alone the wage. An employee without insurance would not afford cancer treatment. A civil servant, even somebody in the private sector, if you give them some salary alone and take away the insurance, very few would afford cancer treatment. It's expensive.
Really sad. Although cancer can be treated, if it is detected early, the problem has started in the system. Detecting is a problem. Treatment is a problem. Let's talk about the stages of cancer: 1, 2, 3, and stage 4.
If you look at breast cancer, it is staged based on size, based on where it has spread to. So size and where it has spread to. And most cancers, most solid cancers are staged like that. Others are staged based on how inward have they gone. So just understanding that stage 1 would be an early disease. Stage 1 and 2 would be considered early diseases. And stage 3 would be considered a locally advanced disease. And stage 4 would be considered a disease that has gone beyond the regions which are considered local. So like if you have a breast cancer and you have lymph nodes involved with cancer in the armpit, then it is still locally advanced disease because it's still local. You can take them out with surgery. But if you have got breast cancer and you do your chest x-ray and you see there's a lesion in the lung, you suspect that cancer has gone to the lung, then it is a stage 4 disease. So stage 1 and 2 are considered early, they are small tumors. Stage 3 is considered locally advanced tumor, and stage 4 is considered advanced disease. So most of our patients come between stage 3 and 4. It's very expensive to treat. Some cancers must have surgery, regardless of stage. Others will only require any of those treatment, chemotherapy or radiotherapy, and it's enough. Like a stage 1 skin cancer would just require radiotherapy, and it's done. Some breast cancers now can just require chemotherapy, and it is done. But other cancers will still require both chemotherapy, radiotherapy, and surgery before it is done. So it largely depends on cancer. So I think it's just good for patients to know that these 3 or 4 options will be made to them depending on their cancer, and it is always protocolized. We'll be following protocols that have been proven to be working elsewhere. So it's very difficult to say like this will be the treatment for stage 1. So now, research, when you are doing research, you do research when you did not intend to do it. That's when you have good outcome, good results. So there were trials among patients who were not fit for surgery, but they had cancers that were considered best treated by surgery, but they were not fit for surgery. So they were given these other treatments, and the cancer completely disappeared without need for surgery. So that provided evidence that it is possible. So now there is what we call de-escalating surgery in certain cancers. So there's that movement. If you look at our publications now, people will be talking about choosing wisely between what you want to give your patient. You want to think whether it's going to add any benefit or no benefit. So since there have been many survivors who did not require surgery and their cancers did not come even at follow-up, so there are many people now who are trying to exhaust the medical options in many cancers before they would consider surgery. So there will be changes in the future, and new molecules will come that will take away surgery.
Now, let's talk about the good things. You've talked about the good and the grim. Looking back at all what has been done, the challenges, what can you talk about in terms of Tanzania as a country, and in terms, you're also a researcher, what are some of the best practices that we have excelled in Tanzania, and what are some of the things that we can boast in terms of treating cancer?
You look back to when Ocean Road began as a small unit within Muhimbili National Hospital to what it has grown to be, I think that alone is remarkable. But also expanded the cancer care across the country so that patients now take shorter distances. Like patients from Lake Zone now just go to Bugando and they'll get their services. And if you go to the northern side, Kilimanjaro is starting their radiotherapy services in this November. They've already been offering chemotherapy. Dodoma is constructing their radiotherapy bunkers. They're already offering chemotherapy. So probably by next year, they'll be offering radiotherapy. And there's another government center being established in Mbeya that will also offer radiotherapy. They're already offering chemotherapy. So many centers are already offering chemotherapy, which itself is a boost. I think the screening for cervical cancer is also doing well. Many women are being diagnosed at early stages, which would be treated easily with simple gadgets that are easy to administer even during outreach services. But yet there are still challenges that patients are still coming late. So there was a study, I think, from Kilimanjaro. They were asking patients what they think their disease is. And the answer they gave dictated where the patients went for care. So when patients said it was a curse from God, that's why they're having disease, they go to houses of prayer. When patients said they have been bewitched, they go to a traditional healer. When patients felt like they ate something in the environment that it's contaminated, that's why they're having a disease, they come to the hospital. And those were the fewest. Those who think that they got something from the environment, they're very few, less than 30%. So 70% will either seek care elsewhere. And it's difficult to force them to come because you look at the capacity of caring for them, and you see that we don't have it. If all of patients were to come in time, I think we would be overwhelmed. So sometimes nature chooses how you manage small resources, but maybe it makes us also not do a lot because we are not very active. We are happy being assisted by traditional medicine. So I think our myths are also bad. Like for me to diagnose a cancer, I need a piece of tissue. And there are a lot of myths about obtaining that tissue. Many people feel like the cancer grows very fast when you take a tissue from it. So even when they are seeing it coming, but they say they will want to take a tissue, so they stay away until when they are very uncomfortable with the disease. So I think more public awareness, especially not from the medics. You know, there are a lot of negativity when programs come from the global West. People think somebody is trying to clone them or trying to do something on them. So survivors are the best, but how do we engage survivors? How do we engage media people like you during cancer awareness months like this? How do we go and understand what they think as a community and tell them what we think as medics? I think those are the remaining gaps that we have so that patients would come early.
Finally, what is your final take? Looking back at your career, what are some memorable things that you can think about that have never left your mind in terms of working with cancer patients and doing research? And what is your final takeaway message to anybody who is listening today? Cancer survivors, people who do not have cancer, policymakers who make laws, donors who give money, and also people who support cancer patients.
I have a friend who normally says that the quality of care that I will receive as me is exactly what I'm offering. Yeah, so it has been my passion to try to improve what I offer because I don't know when I will need it. So train others, make sure they are very good at doing it because that's my doctor. I think that has been my passion and it has helped me all this to stay focused with what I'm doing. Two, there were cancers that we learned and read in books, and we grew up seeing all those patients left to die if they cannot afford going outside. I think it's time to avoid sending our patients abroad. I normally say, like, poor patients go to traditional healers. Patients with money waste their money trying to cheat death by going abroad. Most of these patients who go abroad, we already know that their disease is advanced and nothing can be offered because they're the same protocols. We didn't manufacture medicine here. They're manufactured by them. And we read protocols for them. So they die of cancer. So what guarantees you that you are not going to die of cancer when you go there? Because when we are sending them abroad, then we are not developing our own. We are not funding our own health system. And so we end up complaining that we don't have resources, but we are sending resources to somebody else to be able to manage their patients. So I would encourage my government, and if you are to help me, try and say that let's build it locally so that everybody benefits. There is equity. It's always good to be treated surrounded by your relatives. And even if it meant to die, dying by the people who know you would be a more comfortable death than suffering alone abroad. Public-private partnership is definitely good. We have I think we have 3 private cancer treating facilities. I like one in Ifakara actually because it's located very deep in the village at Ifakara and offering the same quality of care that you would get from Ocean Road or from Aga Khan or from Besta. Public-private partnership is the way to go. Drugs are still very expensive. It's time to promote local production of the generics. It's easy with medicine because patents only last 10 years. After 10 years, the formulas should be known to everybody and everybody should be able to produce. But finally, to encourage local research, I think there need to be funding. And you can only fund if you are treating patients because patients cannot pay for your research. They cannot buy medicine and you are doing research because then they'll not be uniform. they'll only be buying what they can afford. So we need to do our own research and generate our own data and know what is working and what is not working. Finally, calling upon philanthropists in Tanzania to support our work, support patients living with cancer, support cancer survivors so that they save more lives.
Thank you so much, Professor Larry Akoko, for your time. Thank you for the insights that you have shared. And although the picture looks grim, there's a lot of hope. Like you've said, there's a lot that has been done. I love your closing remarks that we should build locally and we should create equity, that nobody should die of cancer because they do not have medicine, because nobody chooses to be sick. So the government needs to invest, and also we need to invest more on research, and also we need to produce our own medicine to treat our own people. So thank you so much for tuning in to Discovering Africa Through Technology, the home of African experts with African solutions. Until next time, this has been your host, Razia Kulatein Mwawanga. Until next time, as we bring you great African minds and experts as they unpack African challenges with African solutions.